Hello, everyone. My name is Dr. Megan Rybarczyk, and I'm an assistant professor of clinical emergency medicine and the Global Emergency Medicine Fellowship Director at the University of Pennsylvania Perelman School of Medicine. And I'm very excited to talk with you today on this topic, global health equity. So as we begin, I have no specific disclosures regarding this talk. However, I do want to start this talk off with the caveat that I think this is better as a discussion. So I hope you take the limitations of my perspective today, of the language that we have in general surrounding this topic, and I hope it spurs additional discourse and action going forward in this important field. So what are the objectives of this talk today? After the session, I hope that you all will be able to review the history of global health. So I think it's really important to talk about where we've come from to see where we are now and how we can move going forward. I hope you're able to understand some of the important components and considerations when we are talking about global health equity, and to also explore some methods for engaging in the field of global emergency care with a particular focus on equity. So first, let's start with the history. And I think in starting with the history, we just need to talk about what global health is in general. So think about all the definitions you've heard about what global health is. And I want you to think about those for a second and think about where there are components of the history of global health in those definitions, how they try to incorporate or not incorporate aspects of equity. So just I want you to think about what is your definition for global health? Well, when thinking about a definition for global health, this is the one I like to go to. And as you can see, this was proposed by Copeland and co-authors in The Lancet in 2009. So it's now been a little while. And even at that time, though, there was this emphasis on equity. Unfortunately, I think, it's a great definition to go through, and I'll go through the whole thing here in a second. But I don't think we've actually achieved what this definition was hoping to put forward yet. And so I want to keep this definition in mind as we go forward, because I think it does really help frame what we're trying to do. And I think it's one of the best definitions that I've seen out there to date, although I don't think we've quite fulfilled the spirit of the definition just yet. So keep this in mind, because I think it's a goal for us to aspire to. But to read out the entire definition, or at least kind of the paragraph surrounding this effort to define global health in this paper, here's the whole quote around that. So global health is an area for study, research, and practice that places a priority on improving health and achieving equity and health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions. It involves many disciplines within and beyond the health sciences, and it promotes interdisciplinary collaboration. And it's a synthesis of population-based prevention with individual-level clinical care. So again, there's many, many definitions that exist, but most tend to have these components, components such as equity, global conceptualization, thinking about causes, means, and solutions, a sense of obligation, having a multidisciplinary approach, consideration of all actors and mutual respect, and then both reactive as well as proactive approaches. So I think there still are some limitations to the definition that we could, discuss on end. But I think this is one of the most comprehensive to date. And again, focusing on equity, which I don't think we have quite achieved yet. So, this has been around since 2009, but we haven't quite gotten there yet. And here I think is really why. And it's really our history. So if you kind of take a step back and look at how global health, or the concept of global health, the field of global health came to be, it really started out many, many years ago with its origins in tropical medicine, unfortunately. So up until the 1800s, the field was really tropical medicine. It was very focused on medicine that pertained to military medicine or medical missions. So the goal was really to safeguard explorers and colonists. And the focus of that too was not only to safeguard those, but to also civilize and westernize populations as well too, and use it as means, in religious efforts to convert other populations as well too. And so it really was focused primarily on like communicable diseases, and it was primarily focused on those who were going out into different populations, such as the colonialists and military medicine. So as you can see, was very, very limited, and it was very focused on colonialism and everything surrounding that, and kind of conquering and converting and kind of overcoming other populations. So as you can see, very, very colonialistic language when we talk about this. One of the earliest schools of tropical medicine was the London School of Tropical Medicine. And if you look at the full name of that institution, School of Tropical Medicine and Hygiene, there was a lot of terminology surrounding this kind of work at the time that was very inequitable and very focused on, as I mentioned, like conversion and colonization and imperialism. So then as we go forward, looking at the kind of mid 1800s up through the 1900s, we do, start to have a break. So, up through the 1800s and things like that, we had these large empires. It was all about conquering and converting and all of that. And as we kind of move through this time, you start to see the breaking down of empires, the formation of new borders. And so then we start to focus on international health. So the terminology changes from tropical health to international health when we talk about this. And in 1851, actually, there was the first International Sanitary Convention. Unfortunately, still that very biased terminology, but it was one of the first times that people came together to try to draft some international health policy. Unfortunately, nothing was really agreed upon, so it was a great effort, but at least it was an effort for people to come together and try to think about this more at one common table rather than not. Around this time, too, we have the formation of the International Committee of the Red Cross in 1863. That's now part of the International Red Cross and Red Crescent movement, along with the International Federation of the Red Cross and Red Crescent Societies and National Societies. And so we start to have these kind of larger organizations that are really trying to cross borders and focus a lot more on the health aspect of things rather than using health and medicine as a means of conversion or colonization. In the 1860s through the early to mid 1900s, we start to see the development of international collaborations focused on health, obviously affected by many of the other large events that happened during this time, such as large cholera epidemics, yellow fever in the Americas, the 1918 flu pandemic, World War I, World War II. So kind of all these efforts are kind of happening at once, and it kind of really culminates in the formation of the UN and kind of the medical aspects of the UN and affiliated organizations in the 1940s or so. And so, several of these organizations that were started, the Rockefeller International Board of Health, the ICRC, Pan American Sanitary Bureau, again, some limitations in the names in terms of language and trying to talk about this topic, but at the very least, these groups merged together and formed the WHO in 1948. A little bit before that, in 1944, in New Hampshire, the Bretton Woods Conference, this is really important to note that the World Bank and the IMF were built. So they were originally tasked to rebuild economies in post-war Europe, but as we know, they now provide loans and grants to resource-denied countries, and the IMF is the financial agency of the UN. So really important to note that those came first before really the formation of the WHO. And as I'm sure many of you know, there are a lot of differing views on kind of how the operations of the World Bank and the IMF happen and how finances really drive a lot of this too. And as you can see, they were established even before the WHO, unfortunately, but they're a large part of kind of what happens in this space today. As we move forward, though, we're really trying to bring those organizations together, have the WHO kind of take the lead on much of this. And by the 1960s and 70s, we're starting to have a lot more conversations about how we think about global health, how we think about health in general, and thinking about even health as a human right, which really comes out of the 1978 Alma-Ata conference that was with the WHO and UNICEF. They led this international conference on primary health care. focusing on health for all, primarily focused on primary health care, and redefining health not just as merely the absence of disease, but a state of complete physical, mental, and social well-being. And so, we're starting to reconceptualize this and think about this with a little bit more of an equity lens, as kind of the early formation of the idea of like universal health coverage. And then from that, in the 1980s or so, we see the rise of international NGOs. And so those are great. We start to have all these organizations really focused on this. However, there's still that shadow of colonialism, as I mentioned, kind of the inequitable financial structures that come with this, and the biases and the unidirectional flow of things really was kept in place through the formation of many of those and the implementation of many of their efforts. As we come more to the present day, 1990s to the present, so we kind of change the definition from international health to global health, to try to really think less about those borders that were formed, because even though there was the breaking down of these larger empires and the formation of more nations and international borders, people saw the kind of limitations of that, and that many of those were very artificial, very influenced by the colonial rules that had been in place before them. And so we wanted to try to there was this effort to really think about this in a more equitable way, and so changing the terminology from international health to global health hopefully helped encompass that a little bit. And at this time too, we have the further rise of the international NGOs. But unfortunately, with many of these organizations, as I said, there was still that influence, that colonial influence, a lot of this top-down approach, a lot of unidirectional flow of ideas, of resources, and control of those as well too. And so, there's a lot of great organizations out there. The Bill and Melinda Gates Foundation, PEPFAR, but as you know, many of these organizations are very focused still on individual disease process. So, Alma-Ata tried to start off with that concept of like, we need to think about this holistic definition of health and what it is. But unfortunately, many of these international NGOs still really focused on individual disease processes, such as, TB, malaria, HIV. And so as we move into the 2000s, people start to ask these questions, we're putting all these resources into these efforts. Why are things failing? Capacity for ownership is there, capacity for work is there, capacity for partnership is there. Why are these failing? It's because we're not actually approaching this from an equity lens. We're not actually approaching these as true partnerships. There's still a lot of that colonial influence in these organizations and in doing this sort of work. And so around this time too, we have the development then of the Millennium Development Goals. There's the Paris Declaration on Aid Effectiveness, really trying to scrutinize how we're looking at this unidirectional flow of resources. So more than 100 countries came together, and they had a goal of by 2010 that there would be better alignment of goals, more equitable partnerships between donors and recipients, thinking about ownership, harmonization, managing for results, mutual accountability. And so in all that, then we have to the transition to the Sustainable Development Goals in 2016. And so we start to see some progress then on thinking about interconnectedness of different disease processes, and then incorporating even, a multidisciplinary approach, like thinking about education, the economy, infrastructure, planet health, and, starting to really hopefully move more away from that kind of siloed disease process approach, and also then hopefully in the process breaking down some of those colonial barriers. Unfortunately, as we still know though, there's still like large threads of neocolonialism, which I'll talk about in a second. There's still, siloed approaches. There's still unidirectional flow of resources and all of that. And so we're getting there. We're moving there. We're starting to fulfill that 2009 definition that Copeland proposed, but we're still not quite there just yet. And I think it's primarily from that history, and then kind of all the inherent structural biases and inequalities that are kind of inherent in the structures that we've created starting now. So that was kind of general global health. I do just want to take a second to talk about emergency care, just more specifically as a case study, just because I think it's important to see where like the history of emergency care in and of itself, and kind of how emergency care has approached this, kind of coming in, later to the table in terms of this history. Although obviously we know our specialty is rooted in all of that in the past, but as you may know, in the 1970s, that's where that's when EM became a specialty in the United States. In um, the 1970s, you have the first the development of the World Association for Disaster and Emergency Medicine. So, right off the bat, really, there is this idea of kind of coming together worldwide and thinking about emergency care and emergency medicine. And that was really around the time that was the rise of the NGOs, the international NGOs, and you have organizations such as International Medical Corps, MSF, developed during this time as well too. And then in 1986, there's the first International Conference in Emergency Medicine. So again, really trying to focus on bringing people together in emergency care. We realize that, emergency care, probably more than any other specialty, is not siloed, and that all these systems are interconnected when you're thinking about referral systems, when you're thinking about disaster and humanitarian response. One emergency department cannot just operate in isolation, for example, as some other specialties can do in terms of individual clinics and things like that. And so really important to start thinking about this from the beginning. And I think emergency care had kind of a unique perspective on this, as well as kind of a unique advantage, kind of starting a little bit later and organizing a little bit later in that whole history of global health spectrum progress throughout the years. And so then in the 1990s, in the US, we actually start to have global EM fellowships, where people are beginning to train in this specific subspecialty of emergency care and really think about this topic more. In the 2000s, we see the rise of WHO initiatives, specifically on emergency care. So the WHO begins to focus on emergency care with specific World Health Assembly resolutions. One of the first one being just kind of highlighting what emergency care is. Just kind of more specific examples, in 2011, the Global Emergency Medicine Academy of SAEM was developed. You have the Global Emergency Medicine Fellowship Consortium in 2012. And then we really start to see like a huge increase, an exponential increase in efforts regarding emergency care after this. And so, as I mentioned, that kind of first WHA resolution 60.22 on health systems and the importance of emergency care systems, but really kind of like from 2010, 2015 on, people really start to see how important it is to think about emergency care in these systems, and how we need to highlight this and put an emphasis on this. So from 2015 to 2018, the Disease Control Priorities, the third edition, incorporated a chapter on emergency care. Fogarty begins to offer collaborative grants for enhancing emergency care research, so CLEAR grants. We start to see a slew of resolutions in the World Health Assemblies over the last few years. So some of the most important ones in 2019, 72.16, emergency care systems for universal health coverage, and how important that is. That was a really exciting time to be in Geneva. I was there when this was passed. So a really important resolution. In 2023, thinking about the integration of emergency, critical, and operative care for universal health coverage. And then most recently, even just this year, we had an initiative to take that even forward. So now the development of a global strategy and action plan for integrated emergency, critical, and operative care. So really exciting time for emergency care, and then really a strong focus on multidisciplinary, collaborative, universal efforts to try to improve health outcomes and think about this from an equity lens. Also during this time, there are advances in humanitarian response from the initial humanitarian charter in the late 1990s, the first kind of sphere standards when thinking about humanitarian care in 2000s. And I think the fourth edition was just released a couple of years ago. You have the development of the cluster system when we're talking about UN OCHA. So, in various aspects of emergency care, from, research and grants to policy, and advocacy for this to humanitarian disaster response. And I think, emergency care would kind of be developed a little bit later than the specialties, had a unique perspective in coming into this, and hopefully focusing a bit more on equity. So as I mentioned, we've started to move from this idea of individual disease processes, and inequitable application of resources, focusing on not just thinking about focusing on certain disease processes that may or may not be important to certain populations and individuals, to now moving to thinking about more systemic change and equity as we move through the history of global health, even as we move through the history of global emergency care. But as I mentioned, we're not quite all the way there yet. There's still this aspect of neocolonialism in pretty much everything that has been done here. I mean, even in those amazing, resolutions, those efforts to think about universal health coverage and all that, there's always a bit of a power differential just because of those structures back from, the 1800s, all of that. And so I want you to think about, as you come into global health work, and even as you think about global health equity, think about those underlying structures. And that as of right now, and probably, going forward in the future, there's always going to be a power differential. Anytime there's inequitable resources, there's inequitable structures, there's, historical, structural inequalities to incorporate into this. There's always going to be that. And so thinking about it from that lens, and starting at least from that point and recognizing that as one place to start. And so that's where we start for now. But I'm hoping, as we go forward and talk more about this, even in our imperfect language, even in our imperfect ways of addressing this, that maybe we can start to have to affect change in this realm. And that's really what we're hoping to do, is to go forward and to change this as we focus on global health equity and as we focus on implementing emergency care with an equity lens. So before we talk about kind of more practical ways of engaging in global emergency care, we need to talk about what global health equity is. Like when we're talking about equity, what are we meaning? And I talked about this topic a couple of months ago, and someone asked me, well, what do you mean when you talk about global health equity? Is it equity in health outcomes? Is it equity in access? Is it equity when we're talking about our partnerships? And I'm like, it's a really good point. Like there are, definitions that are out there. But we haven't actually truly defined global health equity very well. A few years ago, this effort initially started as talking about decolonizing global health. Many of you might have heard that. And actually, I've a colleague forwarded this on in a group chat that I'm in from a conference that someone had put up. And decolonizing global health is not the way to think about this either. I love this quote of the colonizers invented the concept and the name colonization, and now they have invented decolonization. And the partners are saying, we don't want you to come forward and fix the problems that you created. We just want to be treated as equal partners and work together to solve global health challenges. So I think that is where we truly begin to change this. It starts with kind of thinking about the fundamentals, how we engage in this work, how we even talk about what it is in general. So when you look at various definitions out there of what global health equity is, it's the fair and just opportunity to be as healthy as possible or to attain an individual's full potential for health and well-being, and having access to essential health services, regardless of where you live, your socioeconomic status, your personal characteristics. It's making sure that there are no large differences in health outcomes. But as you can see, there's still limitations on that. Like, you could say that, a person who lives 30 miles from any healthcare, can only reach this level of health, as opposed to someone who lives within a mile of good healthcare, can achieve this level of health, and they both can achieve those great levels of health and the maximum level of health, but those levels are inherently different to start off with. And so you need to actually start defining what those things are. So is it this specific level of clean water? Is it this number of healthcare resources? So it's really important to take this a step further and try to make this definition something that is actionable as well too. And I think we're not there yet. These definitions don't incorporate anything like this. And it does take making some hard decisions, and it will start from an inequitable place inherently, but we have to, I think, start somewhere. We have to kind of take where we're at in terms of the structural determinants of health, and everything in kind of that structural, the structural biases, structural inequalities, start somewhere, and work on them in actionable terms, very concrete, very concrete and tangible goals when we're talking about what equity is. So not just health outcomes though, but also in talking about how we approach partnerships and thinking about mutual respect, and just the attitude at which we approach all of this. So as you can see, it's going to be an ongoing discussion. And so we're going to have to agree about what that is, and how we go forward in talking about it. So I don't think we're quite there, but at least we can start the conversation and have this at the forefront. And so I think let's talk about some of the components that go into that. And I think first and foremost is, even though we have imperfect language to talk about this, we have imperfect ways that we start to approach this. I think the first way then is just to approach it from a level of respect. And so the term cultural competence has been replaced with the term cultural humility, because it's that recognition that culture is not a competence or a skill set. It's a mindset and an attitude of respect, that there are differences among populations, among communities, among people, and just coming to the table with an idea of mutual respect and partnership in mind, and equality in crossing those barriers as much as possible. And so, unfortunately, this is really tough to talk about, because it's a state of mind. It's an attitude. It's really just teaching people to be human and have humanity, and all of that. And so, so it can be tough. Step one, though, is to recognize those power structures, recognize kind of the roots that underlie all of where we're coming from, and recognize the inherent power structures and all of that. And so, that's at least step one, and then an attitude change as well too. I feel like, since COVID-19, those attitudes have kind of drifted further and further apart. And I'm hoping that as we continue this conversation and put this focus on equity in the forefront of people's minds, we can start to bring that attitude back to one of mutual respect and a focus on equity. But again, it's really tough. How do you teach this? There's not great, there's imperfect language for this. We struggle with the definitions, all of that. And so just, I think at least starting with talks like this, opening up people to dialogue, having people come to the table, recognizing all the limitations of themselves, biases in themselves, as well as the limitations of the language, and just starting to talk about it, starting from somewhere. And coming at it, like I said, with an attitude of humility and respect, and really like changing that attitude from one of negativity toward different cultures and people from different backgrounds to one of hope. There was a recent Scientific American article where there was an interview with several global health experts on what gives you hope for health equity. And I think that's kind of the crux of it, is the hope part of it. It's that positive attitude and coming together and assuming the best and trying to work toward the best for everyone. All right. Another thing to think about is language. As I mentioned, as we're talking about a lot of this, there are huge limitations in the language that we use, both written and spoken, as well as nonverbal language as well too. So obviously, as you know, in a lot of what we do, in just thinking about health and medicine, a lot of that is promoted in the English language. You think about research and all of that, and so just recognizing that as a place where we're starting from, and how can we work to change that. When you're talking in the space as much as possible, as I mentioned, we all come with biases, we all come with imperfect language to talk with, but really focus on the terminology. Try to use terminology that reduces power imbalances, avoid dehumanizing, derogatory, and patronizing terminology and terminology from the past as much as possible. But again, don't ignore that. That is, we need to own that. That's where this is where our specialty has come from. That needs to be recognized. It needs to be acknowledged and taken ownership of that and responsibility for that and accountability for that, and talk about ways that we can move forward from that. So Also really think about nonverbal language as well too, not only, as we're communicating in groups, but just think about too when you're engaging in the space and as you're working, potentially as residents and fellows and faculty and potentially, having fellowships and training and posting things on social media and on websites. Be very mindful about the impact of pictures and branding in promoting like neocolonial ideas, as well as perpetuating some of these inequities and stereotypes. And always think about like consent as well too when thinking about posting things also. So I just want to do a couple short exercises just to give you some examples of this as we go forward. And I think I've already kind of worked in a few as you've kind of seen some of the terminology that I've been using throughout the talk so far, but just to give you some more concrete examples. And this is from the GHERD curriculum from the American Academy of Pediatrics. It's their word soup activity, just in thinking about how terminology could really influence the way that we talk about this and have a lot of connotations and emotions and history and everything incorporated in it. So first of all, just the change from thinking about equality to equity. Terminology talking about things like first and third world countries. In the past, this hierarchy, emphasizing a hierarchy to potentially high and low income countries, or even I think more appropriately thinking about the terminology resource denied and not even resource limited. So recognizing that the prior structures that really resulted in a denial of resources to many of these areas rather than, inherent limitations in populations and things like that. And then, as I mentioned, thinking about cultural humility or cultural respect instead of cultural competency when we're talking about this. So I think here's just a few examples of how language can really impact how we talk about this. And then I just wanted to give an example too of some pictures. And so just a quick warning that some of these pictures that I'm going to show in a second may evoke very emotional responses, and they should in many ways. But just wanted to highlight this as being mindful about kind of the nonverbal communication, pictorial communication that we use in working in the space and talking about this space. So some of these pictures you may have seen before, but people have really referred to the way that this is portrayed in terms of the pornography of poverty, voluntarism, saviorism, and all of that. And so it's just really important to keep that in mind when you're talking when you're working in this space in terms of the language and the messaging that is put out there in terms of not only the words that you use, but the nonverbal communication as well too. We need to think about access and resources too when we're thinking about global health equity. So we think about this a lot when we're thinking about teachers and learners, where that takes place. So kind of more concretely when thinking about those kind of things, like who is equipped to talk about this. So I'm definitely not one of the best speakers on this topic. Who is the best to teach about global health equity? We need varying perspectives on what that means to different people in different environments across the world. Another concrete example, who is really best equipped to give a lecture on TB? Definitely not me. I see very little, if any, TB in my practice. And so when you're thinking about that expertise, we need to really tap into those areas of expertise on folks who have that experience and elevate that when we're thinking about equitable use of access and resources and equitable promotion of expertise across the world. Who are the learners? Who's the target? Kind of same way. So when we're thinking about exchanges, specifically like short-term experiences in global health and students going abroad or coming here, like how equitable are those exchanges? Is it always one side going to the other, or is it an actual exchange? And then how do you engage in that? There are limitations in terms of visas, in terms of resources to be able to travel, if you're doing remote work, who has internet access, all of that. And then, in terms of education and training, who controls content, who controls data, who controls the agreements, the memorandums of understanding, the financing for these type of projects. And then when we're thinking specifically about healthcare, like, who determines what are essential resources? What does equitable access actually mean? As I mentioned before in that example, someone who's 30 miles from healthcare versus someone who's a mile from healthcare, like how do we define that, and all of that. So I think these are important concepts to keep in mind. And all of this too, representation and coming to the table from that aspect of mutual respect and partnership. So who sets priorities, who sets the agenda, who sets standards, and then in all of this, how are partners portrayed, associations with prior, um, uh, unfortunate stereotypes and things like that, from all aspects of the partnership, the concepts of saviorism and all of that. So be really mindful, in these sort of exchanges and partnerships on, promotion, recognition, representation, making sure that everyone has an equitable seat at the table. And finally, too, as I mentioned, thinking about like recognition and promotion. So when we're thinking about research and authorship, avoid parasitism, recognition, make sure there's equitable access and sponsorship for people for awards, appointments, grants. And keep in mind that it's not the same everywhere. Our standard for promotion, for recognition, for awards, all that kind of stuff is very, very different. So this is just one example from a paper that I published with my colleagues last year with our work in Pakistan, and it was very eye-opening to me that none of them wanted to be last author, and that in their setting, the first 6 authors are the ones that have the recognition in terms of promotion and all of that. So really important to keep that in mind and have those open conversations, because it's don't just assume that the structures are the same everywhere. So really important that to keep in mind when you're coming at this through a lens of partnership and mutual respect, and thinking about having that space to ask questions, to learn, and not just assume. So I think those are some of the big concepts when we think about just how we approach this field, from that kind of the initial attitude, and then think about kind of more specific things in terms of access and resources, promotion, and all of that. But then how do you actually apply that? We got to start somewhere. As I mentioned, we have these beautiful abstract definitions of global health and global health equity, but they need to have kind of concrete things, actionable points that we can put into practice. So how do you actually do this and engage in equitable global emergency care going forward? So I'm just going to highlight a couple of areas as we finish out the talk. So number one, maybe one of the easiest ways, but then as I'll mention in a second, not so easy ways, is just to donate. Not everyone can engage directly in this work. Not everyone feels like they're equipped to engage directly in this work. And so one of the ways that you can help promote this type of work is just to donate to those who are doing this work. Just make sure, though, that you find and you research and support sustainable and, if possible, local organizations that are very transparent. So there's lots of resources online in terms of finding, the top rated charities, going through and looking at annual reports in terms of how money is spent, overhead, all of that. And so you want to make sure that you're finding those organizations that are accountable to the participants, the partners, the learners, whoever is engaged in their work. That there's that accountability there, and there's transparency in the entire process as well too. And there's great books to read about kind of this topic in in the kind of very general high level terms and thinking about aid and donations, but also then again too, you can get online and find those charity rating websites, and then the charity websites themselves, or the organizational websites themselves, in terms of their annual reports and the transparency and all of that. So think about this as maybe a first step to get engaged in this work and to really have an impact as well too. Direct medical care is another way, but again too, in this is a challenging way, because inherently, no matter what you do, you are going to be, no matter what your personal background is, you are a physician or you are in medicine and you're coming from the United States. And so think about that, like no matter what you do, there's nothing you can do to erase that structural inequality at this time, at least. And so if you're going to engage in direct medical care in another setting, keep that in mind, that there is going to be a power differential that you are not going to be able to erase. And you are going to be coming at it from that aspect of, a higher resource setting into a resource denied setting that you're not as comfortable with working in. It's not your area of expertise. And so, on top of that, just that inherent coming from, the US inequality, you're going to have the experience inequality as well too. And so it's really challenging to actually do this in an equitable way. Because as I mentioned, none of us here's some examples of places I've gone to and worked. These are not, similar to any of the areas that I practice in the United States. And so there's always going to be that inherent difference. And so I think as long as you come into these sort of experiences with that in mind, and try your best to work with partners there to minimize the impact of that, minimize that impact of you, for lack of a better term, really disrupting kind of the local care in a way, and hopefully to find ways to augment it if you can, and also contribute in other ways, I would say, beyond just direct medical care if you're able to as well too. So think about, accountability while you're there. Think about making sure that there's continuity of care also. And really the goal is to, avoid volunteerism. If your goal is to, go, if there's any sort of hint in your mind that you're going there because it's an interesting place to go or whatnot, then it's probably not the best way to engage in this type of care. You need to kind of approach that first with the right attitude, as we talked about, and then think about kind of logistically and structurally how to best minimize the negative impacts that come from doing direct medical care in other settings and not your comfortable or your home setting. So some other ways you can actually really engage in medical care or things related to medical care are, care of displaced populations, refugee health here in the United States. You can think about travel medicine. Those are ways to impact global health and to promote global health equity here. I mean, as there are plenty of places in the US that are resource denied. There are plenty of ways that care is still delivered inequitably here in the United States. And so, that's another way to really engage in direct medical care and perhaps minimize any negative impacts from, all the, structural issues that go along with providing direct medical care. Kind of maybe other slightly less hands-on ways or kind of indirect ways to impact health. Think about, discharge instructions in your facility and making those more equitable and more accessible to people in terms of different languages and in different levels of language as well too. Utilizing interpreter services appropriately, thinking about, waiting room resources, connecting people with community resources, and thinking about kind of the, all of the infrastructural things in our communities and in our lives that impact health and all of that. So, are there community resources that you can refer people to, and then access to follow-up care as well too. So really take some time in your settings to learn what your local resources are so that you can really help provide those to individuals, and they may not just be purely healthcare resources as well. So keep that in mind. And then disaster and humanitarian response is another way to obviously get involved in emergency care. And as I mentioned, as things changed in the history of global health, there were some advances in how this has been done as well too. And really, this is probably the most challenging way to engage in direct care. And so it's really important that if you're planning on engaging in this, that you have the proper preparation, the proper training, and engage in the proper coordination. We have all seen examples of this, even though there have been a lot of advances in recent years, we've seen very recent examples, for example, after the earthquake in Haiti, where this was not done in a coordinated way, in an equitable way, in terms of providing continuity of care, accountability of care, where people many well-meaning and enthusiastic groups just arrived in countries and, promptly ran out of resources like food and didn't have the proper professional training and all of that. And so, that's the absolute worst thing that could happen when you're engaging in work such as this, not being accountable, creating a burden on the system and all of that. And so it's definitely not a first experience thing, because you don't want to create that second disaster. But it is an important way to engage in this work as well, too, because as we know, there are a huge number of humanitarian crises happening throughout the world today. A few examples here. I myself, in the context of my training, have engaged a bit. Some pictures from some of my experiences are here, but it's from my limited experience, I can tell you that this is definitely one of the most challenging ways to engage in this work, and it's really challenging to keep that focus on equality in this type of work as well, too. Just because you're meeting people when they're the most vulnerable they can be, in terms of highlighting those power differentials, those infrastructural inequalities and all of that. And so just keep that in mind. But that being said, there is a huge need out there, and definitely this is work that needs to be engaged in. So there's a lot of organizations out there, kind of similar to, when we're talking about like donations and things like that, do your research. A lot of these organizations have their own storied histories and things like that. And many of these organizations kind of approach global health and global emergency care from varying levels of equality or focus on equality. And so, do your research, vet organizations, talk to folks who have worked with them in the past if you're planning on engaging this work, because it is really important work. But again, too, if you're really wanting to focus on equity, you need to do your research. And just as I mentioned too, you need to understand the process. More than anything else, as I mentioned, this is one of the most complex ways to engage in direct care. And so, there have been advances recently to try to make this work more equitable, more coordinated. As you see here, the kind of the cluster system that was put into place to try to, think about all the different aspects, that go into this type of care. As you can see, health is only one aspect of things. So really thinking about this from a multidisciplinary um, way in terms of really focusing on how to best promote health, to best address the disaster and the acute situation at hand. But then this is a whole continuum and thinking about how can we kind of make areas more resilient or work with areas to become more resilient and to mitigate risk. And then, really pivot quickly to recovery, reconstruction, and transition back to kind of the normal process of things. And so, really trying to focus on this from that equity lens, and especially too, as I mentioned, the sphere standards that are now in place in this type of work. So, really focusing on dignity, respect, equality, and ensuring that there's accountability and set standards. Like as I mentioned, we have these big concepts that are very abstract, but really concretely putting them into what does this mean in real life, and how can we at least start with something, even though these standards are imperfect and they're kind of the bare minimum that people have agreed on is necessary, but we have to start with a line and a benchmark somewhere and then move from there. Then thinking about research as well too. So with this, you really do want to think about encouraging the focus on local questions that are primarily the focus of the area that you're doing the research. You don't want to be bringing questions in from the outside or and posing questions in areas where they don't make sense, and then working to promote those researchers and those communities and the folks that you're working with in this research as those who are going to, take this research and that message forward. And so, with that, we think about some of these, journals and things that we publish this type of research in, like, Annals of Global Health, Academic Education and Training. But, don't forget to think about other avenues. Like this research needs to be promoted in the setting where it's done in the language of those who are going to benefit from the results of this research as much as possible. So, think about local journals, think about other avenues for publishing this type of work. And any of these, if you are going to go for some of these kind of more broadly reaching journals, they need to be open access. They need to be accessible as much as possible if you're doing that. So just think about that when you're engaging in research. So a great way to partner with colleagues, promote colleagues, and work with colleagues. And, this is a huge need in many, many settings in working in the space, but in approaching it from the equity lens, ensuring, that research processes are strictly adhered to, local IRB processes, as well as home IRB processes. So make sure all those structures are in place, the appropriate agreements are in place, making sure then the local researchers and partners are the ones that are focused on, and then that the results of that research go directly to those who are going to benefit most from the results of that research as well too. In the language that it should be, in the journals that are accessible to them, in the other avenues that are accessible to them as well too. And then if there isn't an avenue that is accessible to them, working to make an avenue accessible to them. Education, I think, is one of the best ways to really engage in this because it really involves a lot of partnership and teamwork, though keeping in mind where the expertise lies, who should be the teachers, who should be the learners, and all of that. So I think this is a great way to really engage in this. Just kind of one example of one of the projects I've worked on, it's the certification program in emergency medicine in Pakistan. Just kind of like thinking about how we can really engage in ways that really promote partnerships and teamwork. I think this is one of the best ways to do so, just because you're all learning from each other. You create these spaces for, feeding ideas back and forth. You bring people in from different backgrounds, different institutions to try to learn from each other and to spread ideas. And try to connect them in various ways, both in person, and there's various online ways to do teaching and stuff as well now. And so I think this is a great way to engage in global health work and global EM work, global emergency care work, and to promote those partnerships. And then I feel like a lot of those other things, like the research, the direct medical care, all of that can come out from this once there's that kind of established partnership at the beginning. So I know this has been a bit of a long talk. This is a huge topic to really go into. I've barely just scratched the surface today. And like I said, I'm hoping that my imperfect perspective today and, imperfect language in talking about all this at least starts the conversation for you. And you take this forward for additional discourse, additional discussion and action going forward. So in taking what we've learned today, that global health and global EM have a long and equitable past, which still persists today and really colors a lot of what we do. And so we need to own that, recognize that, and use that as where we're starting from to move forward. And we need to continue to work toward a practical and actionable definition of global health equity, understanding that our language is limited, but that we need to start somewhere, and we need to take these beautiful kind of broad definitions, make them even better, but then put them into actionable items. And then in your practical spaces that you work in direct medical care, in education, in research, really focus on promoting health equity and do that everywhere in every aspect, and not just in working in communities worldwide, but even in our own community where we know that health equity is a huge issue as well too. So I thank you so much for your time today. Here are just some additional resources. I think the slides are going to be shared, so you should be able to have some of these links, but just some links to some curricula that are out there, as well as some recent articles on this topic as well too. And so I hope you enjoyed this talk today. Again, I hope it spurs additional discussion, and I thank you so much for your time, and happy to get any feedback from you, as well as connect with you going forward. So thank you all so much, and have a wonderful day.